I'm Michelle Cowles. I'm the Director of Business Development at Rogers Behavioral Health, and I will be your moderator today. Joining me are two experts in the assessment and treatment of OCD, Dr. Stephanie Eken, Regional Medical Director of Rogers, and Dr. Josh Nadeau, the Clinical Director at Rogers Behavioral Health's Tampa location. Before we get started, I just want to give a quick overview of the format. The webinar is scheduled to be 90 minutes long, and to receive your CEU credits, you must be logged in for the entire webinar. And then a recording of this webinar will be available on our website for viewing later. Doctors Eken and Nadeau will give a 70 to 75-minute presentation, and then I will facilitate a Q&A answer session. So if you'd like to ask them a question, you just tap on the Q&A button at the bottom of the screen and send a message. Since we do have quite a few participants, we won't be able to get to all of them, but we'll try to get to as many as we can and then be available for you afterwards. Now I am going to turn it over to our presenters.
Great. Well, all of you guys are muted, but you are stuck with Dr. Nadeau and I, who are not muted for the next 70 minutes. So you are our captive audience. We're excited to be talking to you guys today. Feels like things have changed dramatically in about a month's period of time. And so we have been talking a lot about OCD in the midst of COVID-19 and what we're doing to try to treat our patients, both from a therapeutic side as well as from a pharmacotherapy side. Hopefully you guys got to see Dr. Marty Franklin speak last week, who started this series off discussing OCD and contamination in the midst of COVID-19, and there will be another discussion next week as well. So I'm going to talk about medication. I could talk a lot longer than 70 minutes, but I'm going to have to share the time, so I won't take up all of it. But I'll talk about it in the context of both therapy and using it by itself. So neither Dr. Nadeau and I have anything to disclose financially. We both just get paid for doing our jobs. So we can go to the next slide. Here are your learning objectives. So hopefully by the end of this, you'll be able to describe at least two pharmacologic interventions to treat OCD, and you can use them alone or in combination with CBT. We want you guys to be able to have at least two ways to modify the delivery of pharmacological interventions for OCD in the light of doing telepsychiatry in any way that you can to minimize objections that might be raised by parents and families or risks that might be increased. And then we want you to be able to identify one way that you can optimize pharmacotherapy treatment outcomes as delivered both as monotherapy or in combination with CBT. Of course, I would much prefer it be in combination with CBT that involves ERP, and we'll discuss like addressing family reservations, management around non-adherence, and safety planning. All right, so things that we will cover. So first off, we'll talk about actual medications and combining them with other treatments for OCD across pediatric as well as adult OCD, and we'll talk about the rationale for those, and then we'll talk about modifications to ERP in light of COVID-19. Dr. Nadeau will specifically talk about some things that you can do in light of telepsychiatry. I'll also talk about some of those things when we're managing medications, getting essential patient data in light of being in a virtual world and how we can keep people safe, coordinating care when we're doing ERP, and managing medications, because obviously most people are seeing two different providers for those things. And then we also want to be able to address patient and family concerns. So while families may be reluctant to initiate medication in general, imagine now trying to do that virtually, how that could be a barrier. We definitely need to manage side effects and also monitor if there's efficacy without seeing people in person potentially. And then emergency and safety planning, and then identifying patients for who pharmacotherapy or medications may not be advised. Oh, sorry, I'm trying to advance my own slides, which won't work. All right, so here we go. We're gonna dive right into talking about medications and combining them hopefully with ERP. So the information in this talk you're going to see is from a range of sources. So some of it is based on research in adults, a lot from the APA guidelines, some of it from child and adolescent, from ACAP, from the American Academy of Child and Adolescent Psychiatry, certainly other research that's been completed, research in adults that we try to extrapolate to at least adolescents, expert consensus and clinical judgment, so all of those sources. Specifically, I'm going to reference, and I'll note them, the APA treatment of OCD guidelines that were done in 2007. They were updated in 2007, and they put out a new guideline watch in 2013. For ACAP, for pediatric OCD, those practice parameters were established back in 1998, and they had a consortium treatment guideline update in 2012, and then there's a little bit of information from the PANDAS Research Consortium too. If you guys haven't had a chance to see those treatment guidelines, those are also nice, and really the first time we've had more clear guidelines that were published in 2017. All right, first we'll do the APA practice guidelines. So you'll see this is straight from their guidelines, it's their algorithm, and you're gonna notice just in general when we move on and look at the pediatric guidelines that there are more options for adults, particularly when you're at the bottom of that algorithm and people have treatment-resistant OCD that doesn't respond to the typical things like SSRIs. And Dr. Nadeau, if you don't mind clicking one more time, because I want to highlight a particular section. So this is where we're really going to spend most of our time, because this is really where most people get benefit, is doing the typical things, right? Getting CBT with ERP, getting an SSRI, getting it at the right dose for long enough, and then maybe some other strategies for augmentation or switching. And then on the next slide, we're going to talk about the pediatric OCD algorithm. They didn't make such a pretty algorithm in the ACAP guidelines, but this is from a pediatric psychopharm book, and it lays out the ACAP guidelines. And so again, you just see in general that this algorithm is not as lengthy, doesn't have as many options at the bottom. And so I'm going to highlight another portion of it, which is where we're going to spend most of our time. So, mild OCD, definitely we're doing CBT with ERP. Moderate, we're going to do that plus maybe an SSRI. But we'll talk a little bit too about, switching to a different SSRI or maybe using something like Clomipramine or other augmentation strategies in kids. But not as much research in augmentation strategies for sure. All right, so I really like to do the basics when it comes to psychopharm in kids because, and I refer to kids a lot because I'm a child psychiatrist, and so I tend to refer to all my patients as children, but certainly even in adults, doing the basics is really important. And it's common for people not to have had the basics done when it comes to OCD. So we always want to start with medication that has serotonergic action. Serotonin is where, we think it's the most important to target as a neurotransmitter for OCD, just like we know it's really important in anxiety and depression in general. There are multiple randomized controlled trials in adults that show reduction in OCD symptoms versus a placebo. So that's really our gold standard, our placebo-controlled trials. And so we look at that we've seen those for both selective serotonin reuptake inhibitors and tricyclic antidepressants. There's over 20 studies that show serotonergic drugs that are helpful in kids in the short to long term. And then there's multiple augmentation strategies. I'm going to tell you, I'm not going to go through an exhaustive list because you can get sort of exotic. It's sometimes with OCD. We want to stay in the typical path. Normally, we don't have to get too off course to treat most people, but there are ones that that we can use and that modulate other receptors that can help us either augment or enhance serotonin, or may go after something novel like glutamate. So certainly over the past 5 to 8 years, increasing research in glutamate modulators in OCD, which have had some promise. So I always talk about FDA approval, although we don't just use FDA approved medications. Certainly as a child psychiatrist, if I did that, I feel like I'd have maybe like 8 medications to use in total, but it is important to at least talk about those. So FDA approved medications for adults for OCD specifically are fluoxetine, fluvoxamine, paroxetine, and sertraline. For kids, it's more limited, and that's the common story. So there's 3, and it's sertraline for age 6 and over, fluoxetine for age 7 and over, and fluvoxamine for age 8 and over. But just so everyone is clear, we use what we call off-label medications in the pediatric population frequently. Both as a child psychiatrist and a pediatrician, I do that because we just don't tend to have the FDA labeling for certain medications. So, you would definitely see people use, certainly in the past, paroxetine in kids. I always love to go over dosing guidelines for OCD because I think, that's where it's really at for SSRIs. And it's something that's a common thing that I see when patients come to me is they tend to be underdosed when it comes to OCD. So I'll take fluoxetine as a common example here. So a starting dose for an adult would be 20 milligrams. And, if somebody came to me and they were depressed or had generalized anxiety, certainly 40 milligrams is a normal target dose. But you'll see fluoxetine, the usual max is 80 milligrams when it comes to OCD. And certainly I've had adults on 120 milligrams. So the common mistake I see is patients have been on fluoxetine 20 or 40 milligrams for 6 months and haven't had reduction in symptoms. And so that's just the first thing that I'm automatically going to do is I'm going to have, an increase in dose as long as they're tolerating it and not having significant side effects. So you'll see, I really like these kind of charts because it shows the usual max and then it shows the occasional too. So, sertraline 400 milligrams. Paroxetine, we're not using as much just for historical reasons with the black box warning, but it's something that is still used some. Fluvoxamine 450 milligrams that people can get up to, fluoxetine 120. Escitalopram at list 60, we're a little bit more careful about doing that because there is some concern about a cardiac side effect potentially that's related to its cousin citalopram. So if we go up to 60, we might get an EKG. On the next slide, I have information about pediatric dosing guidelines. Again, you may not get as high as you would an adult, although if they're 17, 16 or 17, we might. But in younger kids, it breaks it down by pre-adolescent dosing where you might start, and then a starting dose for an adolescent, and then a typical dosing range. I think it's important to think about that starting dose in a pre-adolescent too, because there is a side effect called behavioral activation that can happen in prepubescent kids. And it can look like they're hypomanic or have really bad ADHD. And so if you start at a lower dose, sometimes you can get around that and reduce the potential for that side effect. But once again, you're going to see higher doses of these medications where, typical dosing range, fluoxetine, it has a wide range of typical dose, but it, up to 80 milligrams there, sertraline up to 200. Certainly I've gone above that in my older adolescents, and fluvoxamine, up to 300, paroxetine up to 60. Citalopram we're more conservative about, so we have that asterisk on there because of a cardiac side effect where you have to get an EKG, and then escitalopram up to 40. There's lots of strategies too for treatment-resistant OCD if the first SSRI doesn't work when it's been dosed adequately and for long enough. I also like to talk about the importance of dosing long enough. So sometimes people don't wait for the effect of the first SSRI. But let's say that first intervention doesn't work. Then you have lots of other options. First, you might just switch to a different SSRI. And both in the adult and child algorithms, that's the first move that you're typically going to make is just change to a different SSRI. They all have the possibility to work differently in someone, so it's always worth that shot. I like to use family history to help me guide that as well. If there's, a parent or a sibling or aunt or uncle, some primary relative that's responded really well to an SSRI, I like to use that information. That can be helpful. The other things you can do is you can potentially switch them to Clomipramine or Anafranil, is how a lot of people know that medication. There are side effect issues, but I'm going to talk about that more. And then there's some SNRIs that you could consider, like venlafaxine and duloxetine. So there's just that switching that you could do. And then there are augmentation strategies. Now, as a child psychiatrist, I really like to try to avoid polypharmacy if possible, but sometimes you have to have multiple receptors being modulated in order to have, symptom reduction. So, or they might have a comorbidity that is getting in the way that you also have to help address, that will help them make progress in treatment. So things like atypical antipsychotics, gabapentin, ondansetron, other glutamate modulators like raluzole, topiramate, memantine, those are getting a little bit more exotic. I don't see a lot of people who don't do OCD work almost exclusively. They don't tend to use those a lot, but they are definitely tools in our toolbox. So if someone has failed 2 SSRIs, sometimes you'll see somebody try another SSRI, frankly, because the side effect burden tends to be better than something like Clomipramine, but Clomipramine is effective. It's a tricyclic antidepressant. It's FDA approved in both kids who are 10 and older as well as adults. And it can be used alone or it can be used in combination with another SSRI. So they did a meta-analysis in 2002, and there's actually a newer one than that too, that showed the increased efficacy of Clomipramine over SSRIs in placebo-controlled trials. So that was important information to see the increase in the effect size of Clomipramine, because it does have an increased side effect profile that's not, it's meaningful to patients, and we need to know that we can really help them if we're going to use the medication. So we usually use it after the 2 SSRI failures. I have seen a study, and I actually forgot to include that slide. I'm going to apologize for that now when I was flipping through. I have a really, really lovely study with a graph, but it does show that increased effect size over other SSRIs. It compared it to fluoxetine and sertraline and fluvoxamine. It does require a physical exam and lab work, which makes it tricky in the world that we're in right now. We can get labs, but we have to be more thoughtful about that. So I'm going to talk about that a little bit more towards the end of how we might be able to get labs, but we certainly need a baseline pulse, blood pressure, and EKG on a patient. Now, if those have been done in the past 6 months, then that's probably fine that we can just get that information from their primary care provider. But if there's a serious family history of sudden unexplained death, then you might need an EKG that's a little closer in time to when you want to start the medication. The other consideration, if there's been 2 SSRI failures or more, is switching to a selective norepinephrine reuptake inhibitor. So those modulate both serotonin and norepinephrine. There are no FDA-approved SNRIs for OCD. The ones that people tend to, go to and use, I think duloxetine has been more of a go-to for people more recently. There's no study yet that shows it's more effective than other SNRIs, but I have seen some, more improvement with it. And I think some other docs that I work with feel the same way. But certainly no study backs that up. That is just clinical experience. And then venlafaxine is another one. I think people are more hesitant as child psychiatrists to use it because of some of the difficulties in the trials in adolescent depression with self-harm and suicidal ideation. So it's also harder to come off for adults. Even the extended release version can be quite difficult to taper off of. So there's just some downsides to venlafaxine. And then desvenlafaxine is another one that I think people will use as well and has had mixed results. So there's other atypical antidepressants that may modulate serotonin, norepinephrine, and dopamine as well that people may try as well. I will say a common error that I do see is the use of Wellbutrin as a primary treatment for OCD, which tends just to make people more anxious. affects dopamine and norepinephrine, and is often not efficacious for our population. And you guys may be able to see me fine because my video is on, but my computer screen just went dead. So, but now it's back. All right. So thank you for switching those slides. The other strategy that you'll see a lot of people use is augmenting with an atypical antipsychotic. So they will modulate serotonin and dopamine receptors. So the old antipsychotics were known for their dopamine antagonism, but the newer atypicals really go after dopamine in a novel way with their serotonin modulation. And so we used to think fewer side effects, but now I just say a different set of side effects that we often have to deal with. But there are several randomized controlled trials and a meta-analysis in adults that show augmentation with atypicals can be helpful in OCD. Those with evidence include aripiprazole, olanzapine, quetiapine, risperidone. In particular, they can be helpful in people with comorbid issues. So we really like to use these in kids who may have, or adults who have tic disorders, other anxiety disorders, mood disorders like bipolar disorder, or maybe a treatment-resistant depression, or a pervasive developmental disorder like autism, where we can target other symptoms in addition to their OCD symptoms. So we can see a reduction perhaps in, tics that may get caught up in their compulsions as well, which can be really sometimes difficult to treat. So that's a quick overview of the types of medications that we use. Coordinating treatment is a whole talk that I've done as well with other people. And this ended up being a really interesting information that we gathered as we discussed, like, how do you coordinate treatment? And even now, how do you coordinate treatment? I almost feel like people may be doing a better job as we're virtual in certain ways, because we're just connecting more via video, and we're finding ways to do that in our schedule in a way that we didn't always in person, which is interesting. I hope somebody's actually studying that, but I would be interested in the data. But certainly from an outpatient world, the data is not good about people, clinicians who are the prescribers and the clinicians who are providing therapy, coordinating care in terms of having discussions around patients. So there's not a lot of data on frequency or outcomes of patients who participate in what they classify as split treatment, which would be that they see a prescriber and a therapist separately, versus integrated treatment where they see one person for the same thing. But US claims data, this is an old study because there's very limited studies of looking at this, but US claims data examined a national managed mental health care organization they looked at about 1,500 of their patients receiving both medication and psychotherapy. And pretty much 80% of them were in split treatment, which I don't think is surprising. I think that number would ring true for and maybe even higher in a lot of communities. In a 1997 survey of psychiatrist practices, they found only about 30% of those patients were in psychotherapy with another professional. And then there's no study of short or long-term outcomes in split versus integrated care. But certainly if I am doing the prescribing for a patient with OCD, they really need to be connected with someone doing CBT with exposure and response prevention. And we really want to be communicating. And, which leads to this slide. So multiple surveys have shown that prescribing psychiatrists and therapists do not routinely communicate about patient care, which is not good. But I get it too. I know how busy we all are, right? And so a 5-month study of psychiatric residents and therapists showed contact occurred in just over half the patients in a 5-month period. In private practice psychiatrists, no communication occurred between professionals in 25% of their patients that were treated for more than 6 months. And then communication with medical providers was reported a few times per year among more than 60% of school-based providers. but there's no published studies where like there's a neutral observer who's tabulating the number of contacts between the psychiatrist and the therapist. I know it's hard, and I'm sure people get frustrated sometimes when they try to get a hold of me. Dr. Nadeau, who works in my own organization, sometimes struggles to get a hold of me. So we all are busy, but figuring out how to coordinate patient care is critical. It's actually been interesting in the virtual world now. If I'm seeing a patient, I've been inviting one of our therapists who's seeing the patient into the same meeting with me to see the patient. And it's been great. It's been a really fruitful, appointment for, I think, the patient, for myself and the therapist. So when I think about when we're communicating, there's some really key things from, both sides that I think we have to think about communication with. So from the psychiatric standpoint, I think the psychiatrist should absolutely be discussing if there's been psychiatric hospitalizations, medication changes, a major change in diagnosis. I remember not too long ago, a therapist didn't realize that one of their patients had, who had not been seeing them as routinely, that their psychiatrist had changed a diagnosis and put in a bipolar diagnosis. So seems like, that would be important to discuss. Certainly just in general and how they impact each other. Major changes in symptoms. If as a psychiatrist, maybe I've done a urine drug screen and found substance use, I need to be able to communicate that with the therapist. Psychosis. This is actually, this is where I think we tend to communicate better, is when there are potential concerns around psychotic features, particularly in patients with OCD who we, are concerned don't have insight or might be in early phase of psychosis. Those are the ones where because I think there's so much consideration about what path they're headed down, and we would like to put our heads together, that perhaps we do tend to communicate better about those scenarios. Safety issues, are obviously important to discuss on both sides. New onset or increased thinking, suicidal thinking or intent, and just safety planning in general. And when I think about what I want to hear from therapists and what would be, help me from a prescribing side, is changes in environmental stressors for my patients. The quarantine being a big one, right? So if they've been quarantined or if they've had a loss of a job, certainly people have had significant environmental stressors thrust upon them very quickly in the past month. And in 2020 in general, it's just been a very interesting year. So that's critical. Significant changes in the treatment planning or modality from in-person to telehealth. I definitely want to know if they had switched that. Behaviors or reports indicating medication side effects. So I actually think sometimes the therapists get a better window into this than I do as a psychiatrist. If I'm just doing medication management, I frankly just don't get as much time either. And so you guys tend to get more observations of them over time than the psychiatrist does. Certainly any endorsed changes in medication compliance, again, patients tend to tell their therapist and not their psychiatrist that they have stopped their medication, because there's some side effect that's problematic or they don't think it's working. So I would definitely want to know that. And then similar things that we discussed before, those major changes in symptoms around substance use, psychosis, or safety, and any change in safety risk factors. And I just think it takes a team to take care of someone with significant, OCD symptoms and to help that patient have improved functionality. Certainly, that relationship between the therapist and psychiatrist is critical too, because here's the real deal too about psychiatrists. They give reassurance to these patients. So it's also good for them to have that great relationship with the therapist too, so that they can hear and see if there's anything they can do that, or reduce that might be impacting the outcome of the patient. I think the therapist is the first provider that the families tend to go to when there are issues, and they build that therapeutic alliance with really strongly. So communication from the therapist is critical. I think therapists are in a unique spot too, to really help patients and families understand what the options are when it comes to OCD treatment. My hope is that most patients with OCD are seeing a therapist first, because I hope that they're seeing that first They're going when their symptoms are more mild and or even moderate, and it can be addressed with ERP. And then, therapy too, I think about it from when I'm doing SSRIs, and we know that there's, a potential in kids and young adults, potentially for suicidal ideation with a black box warning, that therapy can help mediate suicidal ideation and OCD symptoms during the time when medications are initiated, or when there are changes that are occurring in medications. So I think that's critical. And then as well, when we are discontinuing medication, symptoms can increase. And so I think it's critical that we can communicate then. And then I've already mentioned that, the psychiatrist, we can unintentionally reinforce OCD symptoms too. Now, I hope that Dr. Nadeau doesn't find me doing that too much, because I do OCD work a lot. So I hope at this point, although I tell you what, some patients are tricky, and so they get me sometimes. But I think sometimes clinicians that don't do this work all the time are really functioning with the best of intentions and don't realize that they are unintentionally reinforcing some symptoms. So, and I always encourage therapists to work with a psychiatrist who follows evidence-based prescribing. I see a wide variety of practices when it comes to medications for OCD. And so we always say first line, SSRIs often need that high dose for OCD. SNRIs are not the first line. They're more like the third line. And antipsychotic monotherapy is not what we typically recommend. There are some cases out there where it may be appropriate, but it is unusual. Augmenting an SSRI with an antipsychotic is reasonable, but just an antipsychotic in and of itself is not the answer for most people. And then benzodiazepines are not effective for OCD, and something that we really want to avoid in everyone, but particularly in kids, because they also can increase risk for impulsivity and suicidal actions. And so we know that they can be habit forming in general, which is problematic. And then when they are used intermittently as well, they can interfere with exposure and response prevention because they reduce their anxiety. And certainly with exposure and response prevention, we are trying to typically increase their anxiety. So it really prevents them from learning from those situations. So benzodiazepines are not something that we want to start. In fact, that's a medication that I often, in adults, am trying to stop. I don't see it too often in kids, fortunately. I really like this idea too of therapist-informed prescribing. I'm going to tell you, this is one of my friends who's a child psychiatrist in California, Dr. Erica Nurmi. This is her slide that she had let me borrow for a talk, because I really, really enjoyed it. That considering from the therapist side, how does that impact therapy and progress in therapy? And if your patient's not making progress in therapy, why not? Because I always, when people say to me, "Oh, I've been seeing a therapist for 20 years," I'm often like, why is that? Like, is it working? Is it effective? Or are you kind of just going back there for tune-ups? Talk to me about that, because we really want them to see us and then hopefully be able to move on, at least for periods of time in their life. And so hopefully they're making that progress and improving their functionality. And so if they're not, we start to question, why not? And so there might be things that can help us guide the choice of our augmentation as psychiatrists. So do they have overwhelming fear, and that's getting in their way, so they actually can't participate in exposure? So maybe they need an SSRI first. Do they have really poor attention? There's certainly comorbidity with ADHD. And if you can't capture their attention long enough for them to complete an exposure trial, that's a problem. Maybe they're really depressed. Certainly, we know up to 80% of people at some point during their OCD have depression. And so their motivation might be really low because they're really depressed. And so we can do something about that. Maybe they're getting stuck, or they have poor insight, or they're oppositional. And so we have some strategies that we can use for them from a medication standpoint as well. And now I'm finally gonna mute myself and give you over to Dr. Nadeau.
Thanks, Dr. Eken. I also kind of want to take a second here and ask Michelle if there were any specific questions that maybe we should cover first.
Oh, yes, thank you.
Hi, Dr. Eken, there were a couple specific questions.
Yeah.
One is, can you speak to the benefit of NAC as a supplement for OCD patients?
I mean, it has some studies in it. So NAC is N-acetylcysteine. It's an antioxidant used for different things, but certainly has been used in the world of OCD, used also for hair pulling disorder, has better data for hair pulling disorder than OCD. And so I certainly, for patients who don't want to do medications, I often can at least get them, if I feel like they really need something more, if they're not responding to ERP, that might be something that is good for them to try. And sometimes we just use it and add it on. I wouldn't say that it's overwhelmingly helpful, but it's it helps with some glutamate modulation. And so it can be worth a try for people. There's dosing that you have to ramp it up to about 3,000 milligrams a day. But it can cause stomach upset if you do it too quickly. Oh, I think you're on mute, Michelle. If you're
Thank you. Thank you, Dr. Eken.
This is the virtual world that I'm used to.
Yep. Another question that we have is, how long is long enough to do a trial with an SSRI?
Yeah, that's a great question. I actually, obviously I could spend this entire talk on medications, but I think, what I tell patients is, I mean, if you go by the classic trials, it needs to be about 12 weeks of giving a medication a try. Certainly in the adult data, that's more clear from some, from studies. However, there's also some meta-analyses out there, and Dr. Franklin and some of his crew have actually looked at this too, that if you're not getting some effect within like 2 to 3 weeks, that you probably should be looking at something else. And, it's interesting that their meta-analysis found that, because I think as a clinician, even though people told me to wait 12 weeks, if at a month I was seeing nothing, it didn't feel good to just stay there and not move on. But again, too, we have to think about dosing. There's this intersection of dosing and time. So I'm going to give an example, fluoxetine, and let's say I'm dosing it in adult. If I'm at 20 milligrams, for 12 weeks, that's not going to do it. I need to be ramping that dose up. So the thing that patients and families may struggle with, and that you have to walk them through, is they kind of want to sit at a dose and wait to see if it's going to work. And I tend to want to put, my foot on the gas pedal, and say, no, we know that low doses aren't typically effective. So let's push and not just sit at that 20 milligrams, because that can really extend the time out for me to determine whether it's going to be effective or not. So there's not an absolute answer, but I would say if you're at a, at least at a reasonable dose and 4 weeks in and you're getting zero effect, I'm 1 to 10 to start down another path. But the studies would say, and all the classic books would tell you, 12 weeks.
Okay, thank you. And I will ask one more, and then we might have to push these to the end. We have a record number of participants in today's webinar. So, could you just address any concerns with using medication for therapy if it undermines ERP?
Okay, I think I understand the question. Yeah, using medications if they interfere with ERP? Yeah. Okay. So, yeah, I definitely would not want to use medications like benzodiazepines. Some people would even consider medication something like Vistaril, which is not a benzodiazepine, but can reduce people's anxiety. They want to take that before doing an exposure session. And I, as a psychiatrist, definitely not recommend that. What I would say, and this is where communication between the therapist and psychiatrist can be really helpful, is say, okay, can we find a different exposure? Maybe that they can start at a little lower level if they feel that overwhelmed that they need a medication to start that exposure. So can we find something lower level to start with? Because what I want them to be on is, I think of medications, and I hope you guys can all see I think you can see my hands because they're in front of my face, but like the foundation that I want is like an SSRI. And then if we have to build off of it, it's going to be an augmentation strategy, like an atypical. But again, I don't want that to happen. Like, I don't want Visceral or a benzodiazepine to be taken right before a session. The only time taking something before an exposure session would be some of the medications that they look into to see if they can enhance exposure. So there's this idea of medication enhanced exposure, but those haven't necessarily borne out as well as we'd like D-cycloserine, but maybe in the future, you know, and I think they're still trying to figure out if there are those kind of medications. That would be fantastic.
Thank you, Dr. Eken. And I will turn it over to Dr. Nadeau, but keep those questions coming because we will have some time at the end of the presentation and we will be able to get back to you after as well.
Thanks, Michelle. Thanks, Dr. Eken. We got to set this up next time so you follow me because it sucks to have to follow you on this. I'm going to talk about the less exciting portion of modifications here. So we'll talk a little bit about telepsych in general. In terms of like, what does that term actually mean? It turns out there's more to it than you might imagine. We'll also kind of talk about how do we get at this information that we need. You heard Dr. Eken talk a great deal about the importance of communication and collaborating and working as a team. How does that work when you're in different rooms, different locations, sometimes different countries? And then we're going to talk about how do we get over some of the barriers that are inherent to communicating via teletherapy. But first, I'm going to try to make the slides advance. There we go. So try not to fall asleep when I say the words, the taxonomy of telehealth. So there's actually a really cool paper, it doesn't sound like it from that title, that was done on kind of what we mean when we talk about these different terms. And I think the kind of guiding principle to take away from this is twofold. The first is that telehealth is not a new idea. We've been talking about the feasibility of telehealth and telemedicine and you know, having robots do our healthcare, if you will. In the 60s, like the 1960s, we talked about this. The other thing that I will say is that if you're not aware of this, and I suspect you are, but we don't always think about it, is that telehealth, telemedicine is around us, and it's been here for a long time. If you're familiar at all with the treatment of things like diabetes, you know that there are certain devices that we will wear that not only monitor your glucose level so you can see it, but sometimes it will just fire that report off to your PCP so that they can track remotely what's going on. What is that if not telehealth? So when we talk about these terms, there's a great deal that's enfolded in the terminology. And there's kind of four different aspects that we talk about. The first thing I would say is that the majority of research to this point that's been done on telehealth has focused on two different areas. The first has been, does it work? So like, can we actually deliver care in some meaningful way to people? Not so much efficacy, but how feasible is this? And then the second has been more the efficacy part in terms of how do we compare this healthcare at a distance to in-person care? And it's all been these sort of small scale studies that we look at. So to some extent, the good news is for researchers in telehealth, this is their wet dream. They have woken up and found that across the country, the only way to deliver a lot of healthcare is via tele. So when we kind of talk about how we configure this, there's really three different ways we can do that. So when we look down at kind of these dimensions of telepsych, the first thing is in terms of the different functions we can perform. And so they call this functionality. And this realms anywhere from consultation, where we're talking about not just between two providers, but also between the provider and the patient. Diagnosis, and I'll point out a lot of times, diagnosis now, if you've gone lately to get a CAT scan or an X-ray, oftentimes the radiologist who's reading that is not in the same building as when you went and got your X-ray or CAT scan. So again, this is already occurring in some aspects. Something else that we look at is sort of the monitoring. So if we look at folks who are chronically ill and might be homebound or receiving follow-up care after a procedure or wound care, something like that. And then this mentoring. So you may have someone who knows a great deal about a new or a rare procedure who's providing guidance, suggestions, and mentoring to newer professionals or people who know nothing about this. The second dimension that we talk about is in terms of the applications. And here really what we're talking about are things like the specific discipline or the medical specialty involved, what might be called the disease entity or the specific conditions we're talking about. We can be talking about the site of care, both where it's being received, whether it's at home or some sort of a common area in a rural town. or the site where it's being delivered. So again, you've got Dr. Eken from a basement, I believe we said earlier today. I'm one of those cats who's hanging out in my office today because the internet is better here. Which brings me to the last point, which is connectivity. So when we talk about this idea of kind of setting these things up, the platform that we use, whether it's a virtual private network, whether it's the general internet in kind of generally speaking, whether it's social networking, and all of these have different levels of security and kind of various ways that they play into the requirements of HIPAA, which is sort of our guiding light in this time. And then finally, when we talk about connectivity, there's kind of been this quantum leap in technology where there used to be an enormous difference between wired and wireless applications, whereas now, for the most part, it's very rare that you must have must have a wired connection in order to kind of make these things work. So there's a number of things that we talk about. Coming back up to
Dr. Nadeau,
Yes,
I'm so sorry to interrupt. We had a couple people say they had are having a little bit of problems hearing you. Could you possibly crank up your volume? Thank you.
I will do what I can. Let's see
Okay.
if I can. Let's see if I can figure out a way to do that. Maybe I'll just sit a little bit closer to the camera and everyone can see what's much a larger face now. So the kind of coming back up to the top of this slide where we talk about taxonomy, not only are we talking about this communication piece, there's also a collaborative aspect between providers. And again, in a variety of locations, a variety of distances from one another. Also, when we talk about establishing policy, and here I don't just mean who's allowed to provide care where, but also ensuring things like equity or notions of social justice and healthcare economics when we talk about the ability to provide this care effectively at a distance. And speaking of economics, ever present is the question of, am I going to be paid for providing this service? Had I gotten into this for the money, I've made a poor choice. However, I also don't want to live underneath the interstate and provide telehealth that way. So when we kind of talk about these aspects of taxonomy, it turns out that it's really important when we're talking about what we mean by the idea of telepsych. So another question that comes up is, does this work? It's great that it's feasible. How well does it work? As with most slides that I create on the fly, I have done this backwards. So I will point your attention to the bottom. A study by Storch and colleagues back in 2011 looked at adolescents, and they directly compared the ability to deliver treatment for OCD in adolescents, both in the clinic, their sort of treatment as usual, and then the internet. Now, the study in particular that I'm talking about looked at having these folks wait on a wait list versus the folks that were receiving care via the internet. As you might imagine, the people on the wait list did not show a great deal of improvement, which is kind of goes hand in hand with what we know about OCD and prognosis. What we did see, however, that was really surprising at the time was this idea that delivering OCD treatment at a distance via the internet, 81% of the patients who were involved showed significant improvement when we kind of looked at their symptom reduction and increase in functioning. More importantly, following up 3 months later, those gains were pretty durable. We showed that 71% still showed the same or higher levels of functioning and symptom reduction. Coming on the heels of this, about 6 years later, a study by Comer et al. Asked the question, well, why don't we go head to head instead of just looking at a wait list? And what they did was they had this sort of kind of family-based OCD treatment delivered via the internet or in the clinic, the same protocol either way. What they found is, again, a smaller study, 22 folks, and notice this is in children, 4 to 8 years old with significant OCD. We showed that the gains across different modalities here were equivalent. And in fact, the internet base showed slightly higher at post-treatment, 72 versus 60%. 6 months later, 80% of the folks who had completed this protocol were still showing these kind of durable gains that we talked about. Something I want to bring your attention to is on the left hand of that side of that slide, where we talk about the fact that the families were strongly engaged in this, which was a huge drawback. Something a lot of people worried about was that people were going to use internet-based treatment as a babysitter. And it turned out that was not the case. We showed that families were quite engaged, that the parent satisfaction was quite high. I don't know that they asked the kids, again, 4 to 8 years old. I don't know what you would get in terms of satisfaction rating. And more importantly, 90% of the families involved completed the study. So if you know anything about OCD and exposure-based treatments, having a 10% attrition rate is remarkable. It turns out that the #1 reason people don't want to do exposure-based treatment is because it's exposure-based. No one likes to be exposed to things that make them afraid, right? So in terms of kind of answering the question as to whether or not this works, turns out the answer is yes. And again, smaller scale studies are what we've had to this point. So the question becomes at this point, how do we get information? So again, we've talked about the importance of communication, collaboration, getting reimbursed, setting meaningful policies. There are two kind of problems in front of us. The first is, how do you gather this data that we're used to having at our fingertips, or by simply asking, stopping by someone's treatment room on a whim, or every time they come and see you, simply asking these questions or observing? How do we do that now? And then closely related are these ideas of barriers to communication. And so we'll talk about the four main types of communication and kind of some of the barriers that are there and how we can overcome them. The first question I would ask you, and it's a rhetorical question because you're all muted, but play along. When you look at these studies for telepsych and how do we figure out what families are best for telepsych studies, have you ever wondered how they figured that out? And it turns out that the places that do studies of internet-based or telepsych, they took the patient flow that was coming into their clinic and decided who might be appropriate for this treatment. So you can see the reaction I had where my mind kind of went out my ears when I thought about this for a moment. And so the question becomes, if I don't have the luxury of having people still coming streaming into my waiting room, how do I find out who is appropriate for delivery of telehealth services? So to the rescue is a study by Thomas and friends from 2018. And what they looked at was kind of weighing out the benefits of providing telehealth or telepsychiatry services for these sort of emergent youth and adolescents versus having them come into the emergency department for a stay there. And the sort of the wickets they set in terms of who is appropriate and who is not were looking at questions of age and social support. So again, I can't be your babysitter when I'm trying to provide therapy. There needs to be someone there to support or just in case. The symptoms themselves can't be life-threatening. So if I have some significant concerns that you may engage in self-injurious behaviors or try to hurt or kill yourself as a result of engaging in telehealth, spoiler alert, you would not be appropriate for telehealth at that time. The lack of significant behavioral dysregulation, which is the nicest way ever of saying that you're not going to put a hole in the wall or throttle out someone around you if I frustrate you or make you anxious in the context of doing exposure-based care. And then last, when we look at these medical comorbidities, when they are very complex, when things are changing very quickly, when it's very difficult to determine through observation and discussion alone what is attributed to what, it can be very difficult to kind of provide this care at a distance and feel safe about doing so. And particularly what we're talking about here are when there have been recent suicide attempts, or when there's a great deal of talk about these idea of suicidal ideation, and the question becoming, are we seeing true suicidal ideation, or are we seeing intrusive and distressing thoughts about, I might harm myself related to OCD? That is something that can make therapists uncomfortable face-to-face. When you talk about delivering via tele, sometimes there's a higher bar in terms of what needs to be achieved to make me feel comfortable about it. So when we look at gathering this meaningful data at the baseline, so if we go way back to like say 2 months ago, and I asked how you determined your patient's symptom severity, or I asked how you determined what level they were functioning at adaptively, it's usually pretty easy to tell that. I can ask a number of people, I can watch, I can engage you in activities in my office and gauge where you are on many different levels. Yes, there are a lot of instruments that we would give that are pen and paper, things like that. Now, if we jump ahead to this post-dystopian world in which we live right now of the COVID crisis of 2020, so the question becomes, how do you gather that data? A lot of it is available to us in terms of the EMR, the electronic medical record, if they have been treated previously. The second that I would point out is, through the nature of delivering these teleservices, you are able to interview folks, to ask them about their own symptoms, to ask them about their own experiences. If you're dealing with kids and adolescents, like Dr. Eken said, we're both kind of kid people. So you want to interview their parents or their caregivers as well. It's really important that you triangulate with school personnel, with other outpatient providers. It can be really difficult to kind of bring school-based personnel into this, particularly when you realize most school services are tele as well right now. And then last is this term that's e-measures, which really just refers to electronic versions of the same measures that you're used to giving. For some of them, that is available. For some, it is not. I have a sneaking suspicion based upon what we're living with right now that a great deal more instruments are going to become available electronically in the near future. When we get away from baseline and we look at how do we determine whether or not treatment is working from our outcomes data, how do we determine whether or not our medications are working in terms of reports of symptoms, effects, and side effects, the question becomes to think very deeply about how and to whom are you communicating these changes? Who are you talking to about the changes that you see in symptom severity? So as much as when we talk about communication, so delivering information one way from a therapist to a psychiatrist or from a psychiatrist to a therapist, there has to be a meaningful interplay and it has to be bidirectional. We have to be talking back and forth as often as possible about what's going on in terms of how severe symptoms are and what changes there have been, or if there have been no changes. If my patient that I'm seeing for therapy has recently started or stopped a medication, particularly if it was at a high dosage or they've been on it for a long time, or you're changing the dosage, I want to know that. As much as we see diagnostic overshadowing, oftentimes we'll see medication-related overshadowing as well, where if I see a change, I'm going to think it's due to what I'm doing with that patient because I'm, somewhat narcissistic, and I'm going to assume I'm a really good therapist. It would also be helpful for me to know that you've increased the dosage of an SSRI or augmented with an antipsychotic. Those are important things for me to know. By the same token, if I'm seeing some changes and I don't know what to attribute them to, I need to be communicating back and forth with that prescribing provider about this. So when we talk about communication, again, as promised, there's kind of 4 types. And if you know anything about communication, there are millions of ways you can divide this. For the purposes of this presentation and what we're talking about, there's 4 ways I want to talk about communication. So we talk about verbal, nonverbal, written, and visual. And yes, I am aware that visual is nonverbal, and so is written for that matter. But when we kind of talk about these 4 ways of delivering information, I think about them in terms of how much effort it requires on the part of the person delivering the message, as well as how much information you can cram into a unit, if you will, of transmission. So for example, when we look at verbal, here I am talking your ear off, and I'm putting a lot of effort into this, and maybe a little too much information. I'm beginning to sweat a little bit from all the effort that I'm putting into this, but I will point out that it's relatively low information density. Per second, per 30 seconds that I talk, if I'm lucky, I can get one new idea across to you. Now, contrast that with something like nonverbal, where it's relatively low effort. I mean, yes, I have to write it down, but once it's written, I'm done with that. And I can actually pack a great deal of information into a sentence, a paragraph, a page of written information. When we talk about, that's the nonverbal, the written, again, there is a lot of effort that goes into writing it, but it is done once you're done. It still is getting across these ideas of these verbally mediated ideas or content or context. And then at kind of the bottom of this list, one of the kind of least common things that we see used are visual communication. And yet it requires very little effort on my part to use a visual aid, and it can get across several ideas, very complex ideas, very effectively. So why do I bring this up? It's not that I'm a lover of talking about types of communication. The reason I bring this up is because telepsychiatry, by the nature of what we're talking about, presents a barrier to communication. It takes away many tools I am used to having. And unfortunately, what we see is with some of our providers, as with many of our patients, when we don't know what to do or when we feel like our normal approach isn't working, instead of changing our approach, we just try harder with the same approach that we've been using that isn't working. That may sound familiar to you if you deal with patients when we talk about working smarter and not harder. So what I kind of want to talk about is how do we overcome these barriers? So again, information density, the reason that we're talking about this is this element of what might be called dosage or treatment dosage. What we know is that regardless of how we're delivering treatment, whether it's outpatient in person, outpatient virtual, intensive in person, residential in person, PHP, IOP, tele, whatever it may be, it behooves us to get the maximum amount of dosage of treatment per unit time that patients are with us. So put another way, if you're an outpatient provider and you're seeing someone for 15 minutes or 45 minutes, you want to get the maximum amount done in that 15 minutes or 45 minutes. There's no kind of gain or advantage to wasting time or to waiting to see what happens. And I'll come back to something Dr. Eken said, which is she's a pedal to the metal kind of lady. And I admire that. I'm a pedal to the metal kind of therapist. I don't believe in continuing to do things that don't work. And I don't tend to agree with the idea of dialing down intensity or dosage because I don't think it buys your patient anything. So as we talk about this, this is why the information density becomes important. If I'm going to talk to you or if I'm going to communicate with you in 30 minutes, I want the maximum amount of information going back and forth during that 30-minute period. So our focus needs to shift to using more efficient means of communication. And on the right-hand side, what you can see are two columns here. First is how often we use these types of communication. You can see the most common is verbal, going down to visual. What I want you to notice is when we look at how efficient those communication means are, we actually do things in the most backward possible way in terms of how commonly we use these types of information. Building off of this, when we kind of talk about these techniques that we use, what that really means for us is we want to increase as much as possible the visual types of information that are available to us and the nonverbal types of information that are available to us. What I'll also point out is if you're familiar with exposure-based therapies, when we talk about visual, one, very important that we individualize, that we make it as attractive as possible, particularly if you're dealing with kids or adolescents. But notice that psychoeducation, hierarchies, subjective units of distress scale, our old friend the SUDS thermometer, these are all visual means of expressing information. And to some extent, we do use them. We need to use them more. And when we talk about these nonverbals, we need to use them more frequently and we need to change them up. You're well aware of nonverbals if you've done any type of talk about active listening. It becomes very important for me to nod my head to show you that I'm listening. It's very difficult to make eye contact with 658 of you, and yet I think I'm doing an okay job of it right now by staring into the steely-eyed eye of my camera. Also important are these gestures. Now I'm talking with my hands and I realized I've moved myself so far forward that you can't see me kind of doing this as I talk. It's very important that these gestures that we use to communicate understanding or confusion or agreement or questioning, that they can be seen. We have limited ourselves to a box like this, so we need to get, again, as much information as we can into that box. So you'll see, again, exposures also falls under nonverbals here. These are behavioral exposures, not verbal exposures. By the same token, on the other end of this, many things that we're used to using, so like written information or verbal information, they are still important. Witness that we're doing this webinar and I'm talking and not using American Sign Language. So as we talk about this, the written piece, we do want to decrease, but if we're going to use it at all, we want it as concise and direct as we can. If you're working on worry scripts or imaginal exposures, keep them brief, keep them to the point, and keep them potent. The same thing with vignettes or with bibliotherapy. You can do those things, but it's very difficult to do them in the moment within the session. And then last but not least, verbal. Try to be as brief and as clear as you possibly can. That's always a good idea, but particularly in this time when you have a limited amount of time, you have a limited amount of attention and resources to deliver this information. So if you're going to give instruction, your best bet is to give it via visual or written means. You can rely upon verbal if you need to, but that should be like your third choice. Narrative psychoeducation can be effective, but where possible, try to augment that or rely more upon these visual means that we've talked about. So the active ingredients I'll point out here when we look at this: psychoeducation, building the hierarchy, quantifying how anxious you are in the moment and how that changes over time, the exposures themselves, and covering relapse prevention. Notice that all of these can be done with those types of communication we talked about that we want to increase. And it follows the kind of tried and true method of instruction, which is I'm going to start off with telling you what you're going to learn and why, which is psychoeducation. I'm also going to cover how you're going to learn it, which is our hierarchy. I'm going to tell you how you know you're going to learn it, which is how anxious are you in this moment. Then we do the exposures, which is actually the curriculum itself. And when we do relapse prevention, really what we're talking about is kind of this idea of consolidation and generalization, or how can you tell what you've learned and how it's useful somewhere else. So notice these are the exact same active ingredients in exposure with response prevention. As always, nothing has changed other than how we need to communicate those ideas. So, I mean, at this point, I want to turn this back over to Dr. Eken, but I guess, Michelle, are there some specific questions other than why aren't you talking louder that perhaps I should cover?
Yes, thank you. We did have a question about since most patients can't get labs and blood work right now due to the coronavirus, and a lot of patients don't have recent labs and have not seen a primary care doctor, can you still start an SSRI or SNRI without having the blood work?
That's a fantastic question for Dr. Eken.
Okay.
Dr. Nadeau, do you want to field that? Yes, you don't need blood work or a physical for an SSRI or an SNRI. That's really specific to clomipramine. I mean, we should obviously be asking questions about their medical history, but that's the great thing about SSRIs and SNRIs. SSRIs in particular are quite, safe. SNRI sometimes can have an issue if there's blood pressure problems for adults or heart rate issues. But those are pretty safe medications to be starting without those items. I am going to talk momentarily too about considerations around labs as well.
Okay, and another question, how involved should parents be in telehealth?
Ooh, do you want me to cover that, Dr. Eken? You want to cover it?
Like we both probably have thoughts about that, but for it first, Dr. Nadeau.
Yeah, I mean, look, unless there's a compelling reason otherwise, so like extremely toxic or really negative family dynamics, I am a big fan of the more parent involvement, the better, regardless of whether you're talking about young kids or adolescents, because look, my time with you is limited in terms of you being my patient. And it's really important that parents, one, understand what we're doing and why. Two, understand what's expected of the patient and kind of what they should be working on. And three, I'm going to be modeling for them as best I possibly can how I want them interacting with their child. I think also it's important sometimes for parents to see the therapist interacting with their child as capable as we believe them to be, as opposed to my kid. So I think when we look at this, again, unless there's a compelling rationale, I am all about maximum parent involvement. What do you think, Dr. Eken?
I 100% agree with you, because I think it's regardless of the platform, whether it's telehealth or in person, we want families involved. Obviously, naturally, families are more involved a lot of times in person if you have a child who's younger than driving age, because they have to bring them to the appointment. But I think we want that involvement, because they need to understand, just like any of us can reinforce unintentionally OCD symptoms, parents are prime to do that. And that's right why we always address family accommodation. But they need to be doing those exposures outside of session. I always say, if you're not doing work outside of your therapy sessions for OCD, you're not going to get back the life that you deserve and that you want. So family, absolutely, as much as they can, be involved. Now, of course, there are a variety of situations that are out there right now, right, that preclude some parents from being involved. They might be a healthcare worker, or they might be an essential worker in some other field. And so we want to try to figure out ways to involve someone, though, that's part of that child's life. And can we also give them a connection into that video from where they're at? That's the cool thing about virtual, is maybe you don't have to be in the exact same spot. If it's appropriate, for the 13 or 14-year-old to be at home and that parent not be there, we can still involve them in unique ways.
And just one more question for Dr. Nadeau before he turns it over. What do you recommend for silence or clients who don't respond to open-ended questions?
That was the nicest way ever of saying I talk too much, probably, asking what I think about silence. It's a really good question. And what I will point out is this: if you think about what the gold standard is here when we're talking about CBT to treat OCD, speaking in acronyms, exposure with response prevention, it's right there. The point of treatment is not for me to talk you through things. I can be supportive, but in the moment, the purpose of treatment and the majority of the time I'm spending with you is going to be about making sure you understand what it is you're doing and why. But the lion's share of it is you doing and showing me, and me asking you a couple of questions upon what lesson you're drawing from what just happened when you did that exposure. So this is a very different approach from like a processing standpoint, or kind of asking what we think about things, or identifying cognitive errors. Those things are important, but when we look at the active ingredient that we're really after here, it really is this exposure piece, and the processing can occur afterwards. I'm also a big fan of kind of utilizing self-guided reflection type of worksheets to debrief yourself after that exposure, which really kind of obviates or absolves me of the need to be involved in that. I'll also point out it gives me more time to spend doing exposures with you, which, as you may have gathered at this point, I really enjoy. So that works out well for me.
Works out well for your patients too, since that's important.
Oh, that's very nice.
All right. Well, should we go on to the next section? All right. Well, we're going to talk about addressing patient and family concerns. We'll talk about just these different, which we've already started to touch on with your questions. So you guys are really like on it and paying attention. So thank you for that. We appreciate your attention because look, I know sometimes when I'm in a video conference, I might multitask. So you guys are on top of it. Thank you. All right. We'll go to the next slide. So this is a question that I've been getting, from my own medical staff, as well as, just docs out there. We've been talking about what do we do, with medications via telemed. The good news is, just like Dr. Nadeau said, telemedicine is not a new concept. I mean, really innovative things have been happening for years. It gives you access to specialists, which is really great. We have people who are ICU doctors managing vents from like states away. So, it's really amazing what can be done via telehealth. But obviously, if we're seeing a patient in front of us and starting medications, and how do we monitor its effectiveness, its side effects, we really talk about eliciting the help of those who are their support people. So parents, siblings, whoever is in their life and part of their, environment at this time. Obviously, things are a little bit unique right now in that they may only have their nuclear family probably as part of their observation. So we would ask that, their spouse, their parent, whoever, help provide observations of what the patient looks like if they're initiating a new medication and or increasing, changing medications, any of those things. Vital signs, we've been able to be pretty creative on. Cardiologists also do this when they do telemedicine. You can leverage some different things. There's technology that's already out there with Apple Watches where it may check your heart rate. There are apps that look at, it is not a 12 lead EKG, it's only a 1 lead EKG, but can give you some information around an EKG as well, that you can do with those kind of watches. People also often have their own blood pressure cuffs that will also get their pulse. So I know we ask every patient now when they admit with us, do you have a blood pressure cuff at home? Do you have a scale at home? Now that one kind of hurts me because I also treat patients with eating disorders, and fundamentally I want no families to have scales in their home. But it does help us if we're trying to monitor side effects, potentially, for a medication. So other things that can be done too, one thing that we worry about particularly in females, obviously, if they've started, if they're of childbearing age, that we want to be able to do a pregnancy test before they start a medication. So we can do pregnancy tests at home. We can have a support person potentially observe that for us. We've even gotten, for if we're worried about the use of substances, that there are now saliva swabs that you can use as point of care tests to see if people are potentially using substances. So it's getting pretty interesting, different things you can leverage. In terms of labs, that's definitely where it gets trickier. So I don't have the ability to draw your blood virtually. I don't know, maybe that'll happen in the future. But there are labs that are open. The question becomes is, do you really need them? Most medications that we use for OCD, like SSRIs, SNRIs, I don't have to have labs. If I'm doing Clomipramine levels become important, and so that's an issue. Also, medications that are like atypical antipsychotics, you really need to be looking at metabolic labs. So I definitely am trying to track down if they've had any lab work in the last 6 months to a year around the metabolic labs. A lot of times adults will have had that if they routinely see a primary care physician. And then the other piece is for labs, for those that are open, we're contacting them or having the patient contact them and find out if there are times that are slower so that we can send them outside of peak times to reduce, their risk for being exposed. And then this slide is really irrelevant of telehealth. This is just in general what I do around managing medication anxiety for patients and parents. So, you know, how do you discuss potential side effects with patients and with kids or with adults? And I am, as I mentioned before, I like to push dose. So there is the possibility for side effect, but the good news is most kids and a lot of adults will tolerate these really well. But what I don't do is I don't go through an exhaustive list of side effects, because anxious kids and often have anxious parents. So going through like the, you know, physician's desk reference of every side effect of a medication is not the way to go. In fact, I try to, when I'm getting in consent, I try to, particularly if I have a child or an adolescent, I might say something like, you know, I think most people tolerate this at your age, this medication really well. You're really good at monitoring what's going on with your body. I just want to know if you notice anything different, and tell me or tell your parents, and let us decide if that's really part of the medication. Because I do promise you, if I tell them that headache, stomach ache, you know, those kind of things are related to the medication, the next day when they have a headache because they didn't drink enough water, it will absolutely be due to the medication in their mind. And so that can really set us up for a bad relationship with medications moving forward. So, you know, I talk to them, I like to see trends. I like to hear if it's really different from your typical baseline. And then I'll talk to parents, or if they're adults, in a little bit more detail. So I think, you know, I want to go through the ones that are significant and potentially dangerous, right, with the parents. But I definitely don't want to talk about everything that can happen under the sun, because a lot of these kids have a lot of somatic complaints anyway. And so and the parents are also looking for changes. So I say, that's great. You let me know, and we'll kind of walk through this together and see if it's really different. And I'm going to let Dr. Nadeau take this one.
So,
And just to let you know, we are coming close to the time to finish our Q&A.
all right, I'm going to pick it up. So when we kind of talk about this idea of medications, as Dr. Eken mentioned, a lot of times kids, and if we're honest, anxious parents, are quite resistant to either starting medications, changing medications, increasing doses to what we feel would be therapeutic. And look, I think this is not unique to telehealth. This is something that happens all the time. And one of the things I'll point out that's rewarding and challenging at the same time about working with kids is that they're a tough audience, man. Like Dr. Eken mentioned, if you talk to them about the fact that, now I need to know if you have trouble breathing and fall over and die, you need to tell me about that, you're going to freak some people out. It's okay to have fun with this, not fun with medication side effects. So when you talk about side effects, intersperse it with some fun stuff. I mean, I want you to try black jelly beans every day because I need to know if you start liking them and you stop hating them. That's really important for me to know that. You know, if you start walking in circles, okay, or you forget how to speak English, let me know that. It's okay to be silly with this. Point out the absurdity. This is no different than we handle exposures to anything else. And make no mistake about it, if you have parents or kids who are anxious about starting medication, this is perfect fodder for an exposure to start medication. I'm not going to spend a great deal of time going over this, although it is really cool, this idea of how we treat these things as exposures. If we want you to swallow a pill, how do we get there? And we talk about this graduated, ever-increasing way of approaching things that make you anxious, in this case, medication. In terms of adherence, again, I talked before about this a little bit, so I'm not going to spend a great deal of time on it. There is this sort of medication overshadowing that it can occur, where anything that happens, if I eat chicken and it didn't agree with me, maybe I attribute that to the fact that I jacked my Abilify dosage up by 5 milligrams this week. Of all the side effects I've seen from Abilify, I don't know that chicken not agreeing with you is one of those. I think a little bit of weight gain is the one that sticks in my mind for that. And so again, this differentiation of what are things that are in the moment indicative of anxiety or nervousness or other things, and how do we differentiate that from medication side effects? And so again, there's some great little kind of mini scripts here that you can use. In terms of response rates, Dr. Eken can probably do this a great deal more justice than I can. Or do you want me to take a stab at it, Dr. E?
Well, I'll talk about it real quickly. So If you look at most studies in terms of remission, about 25% of children and adults can achieve remission with medication. But response is broader definition. So having a 25 to 40%, reduction in the severity of their OCD symptoms. So it can be as high as 40. There's been a pretty wide range, but I will tell you, it's ERP beats out medication in just about any well-done study. It's the combination for, in severe OCD that is so incredibly important for people to have the biggest effect that they can when they're so impaired.
Kind of the last thing we'll talk about here as we wrap this up is this idea of safety and emergency planning. And look at, again, not unique to teletherapy, really important to do safety and emergency planning. There are two things I want to bring to your attention, two kind of big ideas, and each one is associated with a different study. So again, our old friend Dr. Storch and colleagues in 2015 looked at kids and adolescents with OCD and kind of how often and what was associated with the clinical correlates of suicidal ideation, plan, intent, actually acting upon this. What they found was these interesting patterns where suicidal ideation was associated with the presence of certain symptom clusters like symmetry or ordering, sexuality and religiosity type concerns or intrusive thoughts, and also kind of the miscellaneous symptom cluster, which we felt kind of had to do with like a need to ask, tell, or confess at times. Also, what we find, not surprisingly, suicidal ideation was also associated with kind of this overall depressive and anxiety symptoms. As age increased, so did the rate or the likelihood of engaging in suicidal ideation. And also suicidal ideation was observed to increase, generally speaking, as functional impairment decreased. Okay, so why do I bring this up? Because we're talking about a very specific population of folks, whether it's adults, adolescents, or kids, where there are certain things about OCD that might be labeled depressogenic, but there are also certain things about OCD and possibly that concomitant or co-occurring or comorbid depressive symptoms that lend themselves well to the presence of suicidal ideation. So we need to be assessing that, and we need to be asking directly. And as you're aware, if you work with kids and adolescents, one thing parents really don't like to talk about with you is the possibility that their child is experiencing suicidal ideation. Okay. And then last but not least, when we step away from the patients themselves and we think about the caregivers, there's a really cool study that was done by Dr. Monica Wu and colleagues in a couple of years ago now, 2018, that looked at this idea of caregiver load or caregiver burden in terms of patients with OCD. And what we know is that caregivers tend to perceive themselves as being more burdened when we see that how they rate their kids' functional impairment comes down, or the more amount of accommodation they're engaging in as a family goes up, we see that their perceived burden, legitimately, is perceived to increase. Same thing with OCD symptom severity. The reason I point this out is when we move to telehealth and we ask to engage parents or ask parents to be there and be supportive or work one-on-one with their kids on some of these things we've assigned them to do afterwards, they're a captive audience. A lot of them can't leave the home right now, literally. And so what we're seeing is that telehealth in and of itself, not just the modality, but the reason we're using it, has already increased the load. So it's important to not only be looking at safety planning and things like this for the patients, it's also important to be constantly assessing and helping parents problem solve or caregivers problem solve. How do you implement self-care routines? How do you decrease that perceived amount of burden when it comes to caregivers? And I will point out that that's something that we don't always do well in our field. And it's important more than ever now that we focus more upon that.
Oh, thank you so much, Drs. Eken and Nadeau. We have had so many amazing questions that we have run out of time for. And what I would like everyone to know is they can email me with those questions afterwards if your question did not get answered, but they've also been recorded, so we'll be able to get back to you. Also, just a lot of questions on if this was recorded and if they can see the slides in a PDF after. And the answer is yes, those will be up on the website, the Rogers website. And I just also like to let you all know that Rogers is here for those struggling with mental health or addiction, and now potentially more than ever. And we're continuing to accept patients in both inpatient and residential settings in Wisconsin. And we're proud to be offering Rogers Connect Care, our virtual option for those needing intensive outpatient levels of care, which we had questions on as well. So before we conclude, Drs. Eken and Nadeau, can you please share your recommendation for any additional resources for our patients?
Yeah, there's numerous good ones out there. I think, you know, a lot of people are trying to respond to the needs of people in this particular crisis. So the American Psychiatric Association has a really robust toolkit for telepsychiatry if people are looking for different ideas or regulations or whatever aspect there is. And I would say, even though it's by the American Psychiatric Association, it's really good for a variety of disciplines. It's not just unique to psychiatry, what a lot of the items that are in that telepsychiatry toolkit. IOCDF has also done a tremendous amount of you know, work in their own town halls and stuff to try to respond to the unique needs of our patients with OCD and the COVID crisis.
By the same token, the other APA, the American Psychological Association, also offers practice guidelines for this. They also have some really great discussions and kind of, I don't think chat rooms makes me sound old, but kind of forums to be able to discuss things like, how do you deal with the changes that the HHS has made in terms of relaxing, you know, pursuing people for offering telepsychiatry or, you know, telehealth services over state lines. Speaking of the HHS, there's also a link there to get the latest updates from them in terms of news releases. And then finally, you heard Michelle talk a little bit earlier about Rogers Behavioral Health, the Connect Care. And so there's a link there as well to be able to learn more about that and what it looks like.
Thank you so much. That about wraps it up, everyone. I want to remind all participants that those who met the required time commitment will be eligible for CE credits, and you'll receive an email with a link to the mandatory evaluation form. Once you've completed it, you may download it for your CD certificate for the event. I hope you'll join us next week on Thursday, April 23rd for the final webinar within this series of treating OCD during COVID-19. Doctors Marty Franklin and Jennifer Park will be discussing ways to address contamination fears and associated washing and other compulsions during the coronavirus pandemic. And on behalf of everyone at Rogers, we look forward to partnering with you to help you support your patients. And again, I welcome any emails for questions you might have to wrap this up. The doctors received lots of compliments during the presentation, which I assure you I will share with them after. And I'm going to just verbally give you my email as well. It's Michelle, MICHELLE .Kalz, KALZ @RogersBH.org. Did you have any final comments before leaving, Dr. Eken or Dr. Nadeau?
Well, I'm just excited that we had people who are interested in providing really life-saving treatment during a time when people truly need it in a unique way. So this to me just shows the level of commitment that people have in providing really excellent evidence-based treatment. So thank you all for attending. Thank you, Michelle and Ruth and Tyler, all for helping get this hosted. And thanks, Dr. Nadeau, for helping with all the references.
Oh, absolutely. And I'll echo what Dr. Eken said here. You guys are a busy group, and I really appreciate you taking the time today to listen to us talk about this. Thank you so much.
Thank you. On behalf of everyone here at Rogers, we look forward to partnering with you to support your patients. Thank you.
Bye-bye.